I'm privileged and honored to introduce our next speaker, the Commissioner of the Alabama Department of Mental Health, Kimberly Boswell. She was appointed the Commissioner of the Department of Mental Health by Governor Ivey on December 16th of 2020. Commissioner Boswell's goals include furthering an accessible, interconnected, effective, and just system of care for individuals that are served by the department. She has more than 36 years of experience working with individuals with mental illness, substance use disorders, and developmental disabilities. The commissioner previously served as Chief of Staff, Associate Commissioner for Administration, and Director of Human Resources for the department. And over the course of her career, she's worked as a planner to improve human service delivery systems, a program evaluator, a school to work transition coordinator, and also served as the state office administrator for the Alabama Department of Rehabilitation Services. Since November of 2019, Commissioner Boswell has served as a member of the Milbank Memorial Fund Reforming States Group. She's currently a member of the National Academy for State Health Policy and the Long-Term and Chronic Care Committee. She is a member of the Friendship Mission Board, a long-term shelter for men, women, and children who are homeless in the river region, and Mescal's Children's Center for Hope, which is a Christian ministry serving children in Kenya. She earned her Master of Social Work from Florida State University College of Social Work in 1984, with a specialization in planning and program evaluation. She holds a Bachelor of Social Work degree from the University of Alabama at Birmingham, and we are honored and privileged to welcome her here to our meeting today. Commissioner Boswell.
Good morning, everybody. That was such a great tribute to Rosine, and I have to admit, at this point, I'm a little I was so glad to see that. I did have the privilege of meeting her early on when I first came to the department, and certainly knew of the great work she did in the state. And so it was really great to see that. And I would love to be able to share that with some folks in the department. So thank you for that. And I'm going to do my best now to share my screen so y'all can see the PowerPoint. Let's see. All right, can y'all see the screen? Can you see the screen? Okay, great. Great. So I wanted to spend a little time today talking about how we're transforming mental health care in Alabama. As many of you know, we have a lot of projects going on at the moment, and needless to say, it's been a pretty busy summer. And really, one of the questions that really started the transformation that we're in now is asking the question, why are individuals with mental illness and substance use disorder in our jails and in our emergency departments being boarded in an emergency department and not really getting the care that they need? So part of the theme today is really there's nothing new under the sun. While we are in the middle of a transformation, there are some foundational things that you guys are pretty familiar with that are still true today, problems that we're still trying to solve today. And hopefully by creating a better continuum of care, we'll be able to address some of those problems. So I did just want to talk a little bit about some of those trends that we've seen throughout the history of mental health, and then also just kind of the new projects, including the Crisis Care Initiative. But I really love the Mental Health America campaign before stage 4, because it really does describe sort of the transformation that's happening in Alabama. Everything that we're doing in developing the Alabama crisis system of care is really designed to intervene early and often so that people don't reach stage 4 of their mental illness. And for me, that means that stage 4 in our healthcare system is an admission to one of our state hospitals or a civil commitment proceeding that takes away that individual's rights. And anything that we can do in the state to intervene prior to that and to get people the help they need and get them into recovery really is a lot of what the new services are designed to do. But I did want to go back in history a little bit today. In 1861, when Bryce Hospital opened, it was because Dorothea Dix was working very hard to get people with mental illness out of jails. And so here we are, many years later, still having a conversation about how do we get individuals with mental illness out of jails. Back in the day, of course, Bryce Hospital was the largest employer in Tuscaloosa. It was really integrated in the community. You know, today we talk a lot about people being integrated in the community. We talk a lot about people having a meaningful day. But for example, at Bryce Hospital, there was a theater on the back, and the community came into Bryce Hospital for different performances. It was a very integrated setting. And then, of course, the individuals who were there did work and also did a lot of things that we talk about today in terms of wanting to be integrated in the community and having a meaningful day. And of course, some of what happened there through the years also became through the moral treatment movement, the foundation of psychology and social work and psychiatry. And so Alabama really has been at the forefront of mental health treatment, and we really want to get back there. And so for those of you who haven't been to Tuscaloosa in a long time, as most of you know, the University of Alabama purchased the old Bryce Hospital when we got ready to build new Bryce. And so this is a drawing. You can see the dome of the old Bryce Hospital. They did renovate, or they're in the process of renovating the old Bryce. And then this is a new performing arts center that's going to be built on the backside of old Bryce. And then the mental health museum will be on the second floor, and it'll be a walk-through museum. So when people are headed to a performing arts event, they'll walk through to the theater on the second floor through the walk-through museum, the mental health museum. And so it's interesting how sometimes things really come full circle. The old Bryce Main that they're renovating will actually now be the Welcome Center for the university once it's completed. So every student that comes on the capital of, or comes to the campus of UA will start at the old Bryce facility. It'll become the Welcome Center. And many of you are aware and were involved, some folks were involved in the Wyatt case. And as you know, then the issue became overcrowding with over 5,000 people in Bryce Hospital. But one of the things that I wanted to talk about here is, of course, the impact of the Wyatt case and how it established our values and beliefs around how people should be treated. And so once again, when the Wyatt case was settled in 2003, we were leading the nation in terms of our values and beliefs about how people should be treated, their constitutional rights, a set of minimum standards. And, you know, that was really, really significant in the nation. And of course, today, many of our standards that still exist, including our Joint Commission standards, are actually originally based off of those standards that were set as part of Wyatt. And if you go in the hospital today, in a regular hospital, you know, you get a patient bill of rights. And so that concept of people's rights and people's constitutional right to care just expanded over time, and Alabama was a big part of that. So I felt like it was really important to sort of go back and look at our history and how it actually continues to influence what we do today. And then many of you know, and I'll really talk about the item in red. Many of you know the history of closing developmental centers and after Wyatt, and then building the new Bryce Hospital with 268 beds. Unfortunately, as you know, in 2010, the department experienced a $40 million cut in our budget. And at that time, we had to step back and think about how do we manage that? What do we do in order to do the best we can with a $40 million reduction in our budget? And at that time, the decision was to go back and look at our statutory responsibility. Well, our statutory responsibility is to civilly committed patients. And so we had to look at our system, and, you know, we knew that we couldn't cut group homes in the community because we would likely be in an Olmstead situation. And so the state dollars were really in the state facilities. And so we closed the last developmental center, which was Partlow. We closed Searcy and Grill in 2012, and then North Alabama in 2014. The important piece of this, though, is that it drove our system back to that stage 4 and to put our resources into trying to make sure that those folks who were in our system who had gone through a civil commitment were served. Many of you know that we did put 16-bed crisis community. And that was our transition, and that allowed us to bring down Medicaid funds in order to try and offset some of the reduction. And so to kind of answer the original question, you know, our system sort of shrunk itself down in a way with that $40 million cut, and really began to focus almost completely on individuals who had gone through a civil commitment proceeding. And so what prompted our transformation? So at that point, we realized we only had 268 civilly committed beds in our hospitals, and 35% of those beds were filled with individuals who were forensic, had previously gone through some kind of forensic hospital or outpatient setting for evaluation. We saw, of course, an increase in the number of individuals with mental illness and substance use disorders in jails. And those 16-bed crisis residential programs that we put in the community started to have longer lengths of stay. They were originally designed to have 4 to 6 week lengths of stay. And all of a sudden we started seeing that they were moving closer to 6 months to a year. Once again, that whole system was focused on individuals who had already gone through a civil commitment proceeding. The other thing that began to happen on the community side is overall the lifespan, our total lifespan began to decrease. We saw loneliness as a big part of issues in our community, causing additional health-related problems as well as mental health problems. And society with no longer with structures to connect people and relationships. And as NAMI, that's one of the things that I think is really, really important with your family groups and supporting individuals, family members, and individuals with mental illness in the community is such an important part of healing. We know, yes, people need to get treatment. Yes, people need to get medication, need to stay on their medication, but really what helps them maintain consistent recovery is a strong community support system. And that's also true for families. And so that to me is the beauty of NAMI. And so I really wanted today to start with what we're doing for kids. And there's been a lot of discussion around trauma and kids experiencing trauma, and then the behaviors that come with that. And one of the books that I've been reading that I think is really an interesting book is a book written by Dr. David Perry, not David, Dr. Perry, and it's he's a neuroscientist, and then Oprah Winfrey co-wrote the book with him, but the title of the book is What Happened to You? And they sort of propose the question is not what's wrong with you, but what happened to you. And that really, that is the question in the mental health field that we should be asking oftentimes, particularly with kids when we're seeing behaviors that are challenging. And once you ask that question, then you begin to uncover sort of adverse childhood experiences that they've encountered. So here's what we know about young folks, little people, and their behavior. We know that preschoolers are 3.5 times more likely to be expelled than kids in K through 12 combined. Often that is related to their behavior. All of a sudden, a child that has not been in a structured environment and has had some adverse childhood experiences winds up in a structured situation. And that's the first time they've ever had to be in that kind of structure. And there are behaviors that wind up getting them expelled from pre-K. We also know if they are expelled, they're 10 times more likely to drop out of high school, experience academic failure, and have generally a negative attitude towards school. So these days, the negative attitude really is starting at pre-K, and pre-K folks not knowing how to address those behavior problems. And then if that happens to them at pre-K, then they're 8 times more likely as a young adult to be expelled or suspended, and then 8 times more likely to be incarcerated later in life. And so it really is important for us to address those adverse childhood experiences for young folks. And so the Department of Mental Health a few years ago received a grant to start infant and early childhood mental health services for kids birth to 5. And we also received an appropriation in 20 to expand that program. And in essence, what it is putting a mental health consultant in a caregiver's environment. For us, that means pre-K. And so we have a partnership with the Department of Early Childhood Education, and we have mental health consultants who work in the pre-K programs in the state. And as those pre-K programs grow, we'll expand our mental health consultations so that all the pre-K programs in the state will have access to a mental health consultant. Once again, it's all about community. It's all about having that support. And so the intervention is not really about fixing the child or providing therapy. It's really working with the caregiver, in this case, the preschool teacher, to develop a supportive environment for that child. From that, if there are other issues going on in the home that need to be addressed, then there are other services that are offered, including home visitors. DHR does this program now in the Head Start daycares. But really, so much of this is about teaching little people and their parents how to identify emotions, how to regulate emotions, how to impact that behavior in a positive way, and giving them the tools they need to grow and develop social and emotional behaviors that are really very, very helpful as they get older. Obviously, that helps address the trauma, but also later on, if the young person develops a mental health issue or a serious mental illness later on, they do have a different set of skills. They understand their emotions. They know how to develop a social support system. The family understands a little bit better how to deal with some of those behaviors. So we're very excited about this program. It is a program that only a few states have, and we have received national recognition around this program. And it really is probably one of the best early intervention and prevention programs that we have. And of course, we are continuing to implement our school-based mental health program in collaboration with State Department of Ed. We know that 50% of mental illness begins by age 14 and 75% by age 24. So obviously, if we could have really strong mental health services for school-age kids, that would be a huge investment in prevention and early intervention. This past year, in addition to our mental health therapists in the school, State Department of Ed established a position called mental health service coordinators and issued an RFP for schools to apply for a grant to have a mental health service coordinator. Right now, there are 58 of those. Well, there are more than 58. There's almost 100 of those statewide. Our relationship to that is we developed 10 modules for a mental health certification for those service coordinators. And every service coordinator that participates and goes, is hired, must go through those 10 modules to receive a certification in mental health. The mental health service coordinators are really more like what we would traditionally think of as case managers. They're not designed to be therapists, and so a lot of what they do is information and referral. This just gives you an idea of how we're involved in school systems. The mental health school-based collaborative is really what we call Tier 3 services. So it is a mental health therapist who is available for kids who've been identified through the collaborative to receive therapy. And then Tier 2 services are really the mental health service coordination services, where they're working towards trying to intervene with issues that are causing problems in the home, as well as make other referrals beyond the mental health system. The school systems also do some at-risk work in that Tier 2 category. And then Tier 1 is really what the school system does in terms of trying to build a healthy climate in the school. And those strategies are what they call universal strategies that they do with all kids. Last year, we tried to pass a bill that didn't make its way through completely during the session. And it really was a framework for what we believe is comprehensive mental health services in schools. A big part of that really is having a safe, supportive environment in schools, which really does get back to trauma and having a trauma-informed system of care for kids who are in school. Really implementing best practices in the school systems. Of course, mental health service coordinators and the school-based mental health collaborative are a big part of that comprehensive mental health system. And then a part of the modules that we created, and I think it might even be the first one, is the mental health service coordinators are doing a needs assessment within the school to identify what issues are out there, what services are available, where are the gaps. And really, to get to comprehensive mental health services in schools, we absolutely have to address adverse childhood experiences and trauma, because more often, as you heard in the statistics earlier, that is what is causing a problem with kids learning. That's what's causing a problem at home. And so that's something that we have absolutely got to figure out a way to address. And then, of course, as we move into serving adults, there are really 3 major programs in our transformation, our Alabama Crisis System of Care. our crisis diversion centers, our rural crisis projects, and our Stepping Up initiative. The goal, we have very specific goals for the system. Of course, once again, as we did in 1861, we want to reduce the number of people who are in jail. And also today in our emergency departments being boarded, an emergency department is not the place for someone who is in a mental health crisis. We also want to promote no wrong door approach, where regardless of the issue, whether it's a mental health issue or a substance use issue, or even a lot of what we're seeing is individuals who also have an intellectual disability and a mental health issue, or an intellectual disability and a substance use issue. And so the system is designed so that individuals can come in and get an assessment. You guys know that sometimes we get kind of really siloed in our approach. You know, you have to have, you can go in this door and this door and this door. But really what we want to do with the crisis system is have easy access to care. So whatever your need is, if it fits into those three categories, when you come in, you can get an assessment, and then we can send you to where you need to go to get the care you need. We also want to decrease the rates of referral to what I call stage 4, to one of our 16-bed crisis residential units or stay in the state hospital. We all know that sometimes that is absolutely necessary and an important part of the continuum. But I also know that if you intervene earlier, many people can avoid that step if they can get the treatment they need when they need it. And then we also want to develop a regional approach to crisis care through the planning and collaboration that we're doing in the community. So we spent the summer opening the 3 crisis diversion centers in the state. In fact, last week we were in Mobile doing the ribbon cutting on the Mobile facility. All 3 of those facilities have these key components. Access to care is really the main reason we established crisis centers. It is a 24/7, 365 access. And as you know, prior to that, our community mental health centers might offer outpatient, and then there may be an in-home team, but you really couldn't get 24/7 access to care in the old system. As a part of that, we have 23-hour temporary observation beds. So again, someone can come in and get a good assessment, get some testing done and observation, and determine kind of what the issue is and how do we get them to where they need to be. The crisis centers do have what we call extended observation, and that's a 5 to 7 day stay for individuals who are, experiencing more severe symptoms. From that, then the decision is, can they be stabilized in that 5 to 7 day, or do they need to go to the next level of care? And again, collaboration with specialty providers so that no matter who's coming in, we're able to assess them and get them to where they need to be. This is just a map of where the crisis diversion centers are now. Those were awarded last year, and all 3 of them began serving people in May. And they did present a regional approach, and all of them have mechanisms designed to coordinate services within the region. But the crisis centers are actually located in Huntsville, Montgomery, and Mobile. Many of you may remember that there was an appropriation for rural crisis care. Once again, the legislature was concerned about the RFP for crisis diversion and understood that the urban locations were going to be much better able to compete for that. And they were concerned about the rural communities. And so based on the National Crisis Now model, we developed a rural crisis care model. Primarily, that is all about mobile crisis teams and deploying mobile crisis teams in co-response with law enforcement. We have had mobile crisis teams before. We have 5 in our state before this began, but they were not 24/7 access and they were not co-response with law enforcement. And so a big part of the rural crisis model is having that mobile crisis team, having co-response, and really most importantly, having peers as a part of that mobile crisis team, because often, and we've already seen it in the crisis diversion centers, people are much more willing to talk to a peer. They don't really want to talk to the mental health professional. They don't really want to talk to that police officer. They don't want to talk to that EMS guy. But if you have a peer there, they're absolutely willing to talk to that individual. And that's also true in our crisis diversion centers. And we've seen it over and over during crisis calls. The initial appropriation for the rural crisis projects, it was funded through a supplemental appropriation. And this past year, the legislature added $2.5 million to our budget to continue those projects. And so those projects are at Cahaba Center, Northwest Alabama, Southwest Alabama, Wellstone Coleman, and West Alabama. So some of our most rural areas. So that gives you just a little bit, I do love a map, so that gives you a picture of kind of where the rural crisis projects are. I will say for crisis diversion, we received a $6 million appropriation this year. If you looked at that other map, Region 2, which is the Birmingham region, doesn't have a crisis diversion center. And so this past year, we wrote in budget language to say we need additional funding for a crisis center in Region 2. We issued the RFP, and during that process, JBS and Indian Rivers were the 2 out of the 5 mental health centers in Region 2 that applied for that. We anticipate announcing late September which community mental health center will receive that award, and then they will begin to, they'll receive their contract from us on October 1. Also wanted to mention that we have applied for a planning grant for mobile crisis, hoping to be able to expand mobile crisis access around the state. And also the grant is actually a planning grant with CMS. It's Medicaid actually technically had to apply, but what we're hoping is we can get some expanded funding for mobile crisis through Medicaid dollars. The Stepping Up initiative really is, once again, reducing the number of people with mental illness in jails. And it is a national model that we've been working on. Really, this was a project that Commissioner Bashir was very passionate about because it was a very concrete way to start trying to move folks out of jail and keep them from going back. At the policy level, it's been really interesting with the community mental health centers. Part of the Stepping Up project is you have to establish a strong community partnership. There are certain people you have to have at the table, the sheriff, the probate judges, everybody who would be involved when a person is in a local jail or in an ER. And it's really shifted in a way, the way our community mental health centers plan and how they gather information. I was in a meeting yesterday with some folks who were talking about how valuable that stakeholder engagement group was to them doing a better job in their local communities. The service delivery part of that really is putting a case manager in the jail. And so a big part of Stepping Up is putting that case manager there, screening individuals who are in the jail for serious mental illness and substance use disorder. So this is a little bit about year one. At that time, we had 5,562 screenings, 1,732 people screened positive for mental illness. And of course, all of those were referred. As you might imagine, not everyone followed up on their referral, but we did make referrals for all of those individuals. This year, the numbers look really different in a good way. We screened over 9,700 people for serious mental illness, and 955 were confirmed through further assessment as having a serious mental illness. We also screened for substance use disorder, and then 151 were confirmed to have a substance use disorder. We also did screenings in the hospitals. Needless to say, from January 2020 to September 2020 was an interesting time to get in the hospital. And so these numbers would have probably looked even better had we not had COVID going on during that process. Interestingly, we did not ask for funding in our 2021 budget request for stepping up. We were sort of trying to piece it together and kind of do our usual patchwork of funding for the stepping up projects. But members of the legislature heard about that. It had a lot to do with the ongoing discussion around prisons and people with mental illness in prisons. And I think, honestly, just out of sheer frustration, they saw this program and saw that the program was at least keeping people from coming back to jail, getting them treatment, and maybe helping them so that they didn't return to jail and thus eventually maybe wind up with more serious charges and wind up in prison. And it was something tangible. So they decided on their own to appropriate $1.8 million for this stepping up program. We were supposed to expand to 28 counties in FY21. Needless to say, again, because of COVID, we were not able to expand the program that rapidly. And so we did not ask for an appropriation in 2022. We're going to use the 1.8 million to expand over 2 years instead of one. And then probably in our next budget request, we'll ask for an additional appropriation to expand the program statewide. So did want to spend some time talking about 988 and converting mental health crisis calls from 911 to 988, which is a Herculean task, I think, probably. So Public Law 116-172, the National Suicide Hotline Designation Act of 2020, really FCC is designated 988 as the universal number for National Suicide Prevention Mental Health Crisis Hotline, and the deployment of crisis services in conjunction with those calls. And actually, I feel like in terms of resources, National NAMI had one of the best resources around why 988. Of course, a 10-digit number is really hard to remember if you're in a mental health crisis. We know that people can easily remember 3-digit numbers. There's a patchwork of system right now that makes it difficult for people to be able to actually deploy the services that are needed. Like right now, the mobile crisis teams are not connected to the crisis calls that are coming in to the existing lines. And so part of 988 is to create that 24/7 call center that has the ability to dispatch mobile crisis teams and connect people to those crisis stabilization beds and to follow up after the call. Of course, law enforcement is typically the first responder. And I heard a quote on one of the national calls that really got my attention. and it was a psychiatrist who's been working on this. And he basically said 988 is a once in a lifetime opportunity to decouple policing from a mental health crisis. And so really that's the hope of 988, is not every call can be decoupled, but a lot of the crisis calls that are received don't require the deployment of a police officer if you can deploy crisis services or deploy crisis services in co-response with law enforcement. And of course, there are insufficient crisis centers to meet those needs. And so a big part of what we have to do with 988 is make sure that the mobile crisis teams and the crisis centers are available statewide. And then, as we know, often, just like we talked about with before stage 4, and it taken people 10 years to get to the help they need, often people are in a very, very serious crisis, and the situation is not a good situation. And so getting them to that phone call and getting them to crisis stabilization services as early as we can is really the goal of 988. The way that I think of 988 is it's really the thread connecting all of Alabama's crisis system of care. It certainly does include crisis lines, but it also includes deployment of mobile crisis teams, in also connection to, in the form of a bed registry, our crisis diversion centers. And that's really the way the system was designed, and really the concept behind the original legislation on the national level is not just to convert the call centers, but to create a scenario where individuals can get the right care at the right time. And so if you think about it, we sort of have a situation where when you're in a mental health crisis, you can call 911, but you can't get mobile crisis teams, and you can't get to the kind of behavioral health bed that you need. So it would be like having 911, but not having ambulances or emergency departments to address that. And a lot of what we're doing with 988 is a lot of education with our legislators and others around a behavioral health crisis, and this needs to happen. So really for 988, there are the core components are you need someone to call, someone to come to you, and if needed, a place to go. And I just want to say one other thing about 988. We do have a meeting coming up, and of course Kelly is on that committee. We also are establishing 4 subcommittees, and I'll be asking Kelly to co-chair the Certification and Standards Committee with Turk Schlesinger, who's the CEO of AltaPoint. There are opportunities for engagement in the subcommittee work. And so if there are folks who are interested in working on 988, those subcommittee opportunities are open to everybody. There's a legislative subcommittee, a crisis care subcommittee, certification and standards, and financing. And then the question is sort of, what's the future of mental health care? Really where the nation is going is something called CCBHC, or Certified Community Behavioral Health Clinic. And really a lot of that is all about integrating mental health and healthcare together so that we have a comprehensive and holistic view of what's going on with folks that we're serving. A big part of that is crisis services. The blue boxes at the top are the things that must be delivered by a certified community behavioral health clinic. And the items at the bottom are items that can be contracted out with a third party or someone who's already delivering those kinds of services. Alabama was not really in a position to compete for any of the demonstration projects or the SAMHSA funding around CCBHC until we stood up crisis services. And so in order to apply for any of those funds, community mental health centers had to be in a position to deliver 24/7 crisis services. Because of that, we did have a community mental health center this year apply for those funds, and Alta Point received a $2 million award to start up a CCBHC in the Mobile area. Of course, Alta Point was a little ahead of the game because they have a FQHC like in their operation already. So they were delivering pretty comprehensive services, and it meant that they were really able to compete for the funds. A big part of CCBHC is the payment methodology as well, and really looking at incentivizing the outcomes and moving completely away from a fee-for-service kind of approach to mental health care. It really is a funding model that looks a lot like the funding model for FQHCs that has proven to be very effective, not only in giving the providers the funding they need to deliver the services, but also in producing the outcomes that we all look for. And then this just gives you a little bit of an idea of where the funding is coming from at the moment. Medicaid has done a CCBHC demonstration, and then there are also methods under Medicaid now through state plan amendments or through an 1115 demonstration that you can do a CCBHC. And then, as I just talked about, Alta Point, their funding came from SAMHSA. So they received the $2 million from a grant that they submitted in March of this year. The statement at the bottom is really true. We could move forward just working with Medicaid and do that without having to go through the demonstration process. We could do a state plan amendment. We could do 1115 waiver. And so those are the things that we're exploring at the moment. Which way is the best way to go for Alabama. And then I wanted to end with this beautiful drawing. Most of you know we have an art contest at the Department of Mental Health every year. And of course, we did it online this year. This beautiful charcoal drawing of Emmett Till was the best in show. It was done by a guy, we'll call him JB, who currently is in Taylor Hardin Secure Medical. And JB, a few years ago, life was going well. He was employed. He was in college part-time and had a first episode psychosis. And in the middle of that, assaulted his neighbor, a fairly minor assault. But through that, he wound up in Taylor Hardin and is doing really well, will probably be released from Taylor Hardin soon. He is an extremely talented, as you can see, individual. He also sings, he also plays multiple instruments. And then he wrote an acceptance speech sort of when he was awarded this. And when I heard it, I thought, man, I wonder what that guy's IQ is. And I talked to the facility director, and as I suspected, JB's IQ is kind of out the roof because his writing was just not only very well written, but the level of emotion and insight behind it was really pretty phenomenal. And so just kind of wanted to bring us back to why we do what we do. He is really going to be successful. We really hope that he will maybe become one of our first forensic peer specialists. But needless to say, there are a lot of JBs out there that need to get out of jail. And we really hope that the way we're transforming services will help us improve the lives of those individuals. And that is it for me.
Thank you so much for that, Commissioner. Golly, that's a lot of wonderful information. And although we didn't have any questions in the chat, I just want to share with you that everyone commented, you know, everything you're saying to us is just completely spot on. Lots of people making comments about the, you know, school and the early childhood, because early intervention, of course, all of us at NAMI realize that that is such a key part of what we do. And hooray for the crisis centers. You know, we're all very excited about that, about the Stepping Up initiative. One of our members made a comment that he works with an organization, Compact, and they are noticing with the youth, the teens that they work with, that you know, 90% of their issues are its underlying trauma and issues. So we thank you so much for everything that you're doing to improve our system of care for those loved ones and individuals that are out there who don't have family. We appreciate you so much for taking time out of your day and sharing with us today.
Great, thank you. Thank you for the work you do.
Thank you.